I'm Susan Mahero. I work for Nairobi City County. I'm the head of epidemiology and disease control. And I also work at the Emergency Operations Center as the operations manager. So it was hectic, but that was one of the strategies that the country adopted. The lockdowns, it started with Nairobi and quickly to other counties that were also reporting many cases. So we also had isolation of cases and quarantine, and schools were being used as quarantine centers. These were people who were exposed but did not have symptoms. We took them to the quarantine centers. So during that time, we used schools, we used colleges like KMTC, where these people were taken. We had isolation centers where those who had symptoms were being taken. And we also had isolations where we were taking people who were confirmed COVID cases. So these were also a few hospitals that had capacity to take care of these patients. Remember, they required oxygen that was not also easy to access, and the numbers were overwhelming. The government had put a waiver on those services. Initially, they were getting free treatment. Later on, that was lifted, and the patients would take care of their own health care. Again, that was not easy for us because remember, we had informed them that once you are taken for isolation, the government would take care. Soon we were changing the story and telling them you are going to take care of your own health. It was not easy. We also had contact tracing as one of the strategies that we are using to get these patients early and monitor them and manage before the cases would escalate. Contact tracing was good. It had a few challenges because it is a labor-intensive activity. It requires a lot of resources because you need to call, you need to take care of airtime for those who are doing that work, and you need to do it real time so that you get this patient. On the other hand, it helped our patients. It was very good for us because we had one-on-one contact with these contacts. They could get clarifications from us, from the healthcare workers. This was being done by surveillance officers, and they could get information about this disease. They could ask questions and get assisted. Again, if anyone developed symptoms, they had somebody to call back for assistance. And many a time they would call even at night that I've started developing the symptoms, what do I do? So then we needed to evacuate them. And because our EOC was operational that time, we would easily get ambulances from the EOC, this is our EOC, to help evacuate them and manage those cases. Remember, now we had contacts, we know where they're coming from, we have their phone numbers, so we would follow up. And we had a database, a line list of all these cases, those who developed symptoms, what is the outcome. So it helped us track these cases, it helped us track the contacts and manage them. So we also needed to get case management for these cases. Who is managing them? So case management was important. We needed to get the medical practitioners on board so that these cases would be managed adequately. And that was being done in our major facilities because these patients required oxygen. Some facilities were not able to provide that, so Mbagathi was one of our sites. Mama Lucy had an isolation ward for them. We also had KUTRH the KU referral hospital that was also isolating the patients. And Aga Khan, so there was a lot of public-private partnerships that helped manage these patients. There were a few experiences during that time. There were people who were not happy being followed up, even after explaining to them why you needed to be followed up so that we know what was going on. And many a time they would tell you they don't want to be followed up. But after a few days, they call back themselves telling you, now, I need your help. Please forgive me for not allowing you to interview me. So kindly assist me. And I think professionalism came in. Those were some of the lessons that we learned, that you would not turn away such a patient. You still needed to take care of them, support them, ensure they got the assistance that they required. And it brought people together. There was a lot of consultation because this was a new disease. Many people did not understand it, so you needed to consult widely with other colleagues just to know what to do. And we also kept in touch with the national. We had WHO colleagues who are working with us. So we were consulting a lot. It brought many partners together so that these cases could be managed well. We also had a lot of issues with burnout. There were no leaves. People are working throughout. And a year passed by, you are still working. Another year was coming in, the pandemic was still on. So there was a lot of burnout, especially among the healthcare workers, among those who are collecting this data, the surveillance officers. They are always on it every day and producing daily situation reports that were being shared widely. So it was not easy, but it brought a few goodies with it. If you go to Mbagathi, you'll find an isolation center, a big tent that was built there by the World Bank that was meant for COVID isolation. That tent is being used to date. Currently, it is our CTU cholera treatment unit. So we are able to isolate patients in that unit, which would now be posing several challenges where to take them. Remember, again, during such epidemics, you get very large numbers of patients and you lack where to isolate them. So that tent is still there. It is working well for us. It is one of our big CTUs currently in the county. So I think COVID has also taught us a lot of resilience, because now not just like the other epidemics that were being managed, maybe you find a few people are not even aware there's cholera, a few people are not aware, anthrax is there. But now this one was an eye opener, because the health structure was overstretched. People got to know that these epidemics can get out of hand, and a lot of life was lost during that time. And a lot of supervision was required for burial. And this brought many people together, because even the community now needed the healthcare workers to support them, even during the burials. And now the working relationships with the communities improved, because now they realized we need one another. For any disease to be controlled, the community must be involved. The healthcare system must be robust and we must work together to control those epidemics. So we have had a lot of community members getting interested. If they get to hear of Ebola, they call and ask, because they know if you hear about a disease just in another country, it could get to you very fast. So they call, make inquiries about that disease, and we are able to talk and share information and also demystify some of the myths that are running around. So again, because of COVID, we have been able to sustain the EOC because it came in during the COVID time. It has continued to be there coordinating epidemics, and now the EOC is running because of COVID. This is the Emergency Operations Center, where we have those receiving calls, asking anything they want to ask about any emergency, and our number is 1508. So we shared that number widely, so anything that you need to inquire, you call the EOC number. So it works 24/7. So Nairobi is one of the counties with an operational EOC, Emergency Operations Center. I was lucky to be part of the national coordination team. It was called NMAC. That was a very powerful center. It was being coordinated by KDF. So you would work odd times. You would go to very risky places. Remember, we had the high end. One unique thing with the COVID was that most of these cases were coming from the high-end estate. Langata was leading, Westlands, as opposed to Mathare, where you're looking at the nature of the disease, you would think the transmission would be very fast. But again, perhaps it is because of testing. Maybe Mathare were not going for testing, but those who needed to travel, those who needed to know their status, are those who fly out. So maybe that's why those areas had high numbers. A few healthcare workers got infected. I think we lost a few. And a few were sustained. We thank God.
Thank you so much. I am Nahashan Marebe. I work for Nairobi County. I coordinate RAB services. Part of my work is diagnostics, and we had quite a number of things we were doing in terms of COVID testing and mass testing for this exercise. Now, mass testing is where a number of people in their abodes, where they live, will go there, and the majority of them would be requested to come up for testing. We were using the health promotion officers in the regions. We did this quite in a number of areas, that is around Kawangware, around Isiri, around the CBD, areas where COVID had hit. We were looking at the hotspots for COVID, and we could do. So mass testing is testing people en masse, testing people in groups and in drives, and we could do this. We had teams that were doing this exercise. We were looking at the data that was being generated from the facilities, and we had one of the questions in the questionnaire is, where do you live? Where do you come from? So majority of the people would come from an area, and that data would be subjected to some data analysis, and it would show us that this area is having quite a number of people with COVID, and therefore then we would label that a hotspot, and that's where we could now task and then say, we need to visit that area and do some mass testing. The mass testing was open for the public, the general public. It was free testing, only that we were using the health promotion officers in the regions, and they would tell people of the dangers of COVID and the good of testing. We were selling the benefits of why we needed to test them. That when you get tested, we know how to isolate or quarantine you. So the public, the general public, was what we were targeting. Now, COVID is one of the emerging diseases. Initially, when we started testing for COVID and when we started having cases for COVID, people were fearing. Why is so having such a bad flu related to flu?
Yeah.
And then at that point, that worry made people to want to be tested.
Right.
And many of them would come and even come to facility and say, I want to be tested for COVID. I want to know whether I have COVID or not. But then during the whole process, there came some lethargy. And people would ask ourselves, why am I being tested? Even if I have COVID or no COVID, what benefit will it have to me? So people started now relaxing. And now to the healthcare worker. The healthcare workers initially were also very fearful of this new disease. And then having worked in our facility, and everybody is coming to you, the exposure was high. So people are saying, now, I'm working in a health facility, and people are coming here with COVID. When they come with COVID, it means then, therefore, I am at risk of getting this disease. The mask and the sanitizations, the number of times we used to wash our hands, and quite a number of things could not be enough to really protect you from this contact sort of disease. So people used to fear a lot, and then say, wow, this disease might end up maybe killing me. So that could be the challenge. So people used to fear. Number one, there is the agenda of fear. And people fear what they don't know. And then the symptoms and the signs and symptoms of COVID were related to quite a number of other ailments that are with us. So that became now the other thing. Anybody who got some flu, they would say, wow, this could be COVID. Yeah. And then the fear of the real sampling. We used to have some swabs, and the swab was wrong enough to go into somebody's nostrils, and then they could say that thing was a bit, it caused some discomfort in the nares, in the nostrils as we did this. So people could say, wow, this thing ain't one of the best things to have inside you. So people could fear, even if they wanted to know the results, they could fear the swabbing process, that sampling process. Yeah, there was some lethargy from the public to come to testing. However, when people started dying, and much more so in big numbers, and then hunting for hospital beds, hunting for ICU beds, HDU beds, and literally some facilities never had good facilities to isolate COVID patients, the death toll took over, and many people died at that period. Now that is what now hit the people back, and they said, let me then know whether I have COVID or not. Because if I have COVID, I have no ways of protecting myself and protecting the others. But even then, people are still reluctant into being tested, because they were saying that COVID doesn't have a real drug that you can take and then the virus dies. It was what we call maintenance, management. You manage the symptoms, you manage the fevers, you manage the flu, you manage quite a number of other things. You don't really kill the virus. So majority of the people want to say, even if I had COVID, then what benefit would that testing then have on me? But the death toll, yes, at one point when people died, quite a number of them, the public also became aware, and they knew that this thing is then taking toll on us. So many of them came for testing. At a personal level, COVID was really, let me say this, we had personally had a big take in COVID. I also got COVID twice. The number of times I know I was tested and was found with the virus, I got COVID twice. And initially when we started testing, many people feared. We were called by the national government for trainings at both Naivasha, Machakos, and here in Nairobi. Many people feared to go, and they said my age wouldn't allow me to go and start testing people. So when we started testing, many people feared. But I volunteered myself, and I said, I think this service, like any other, I need to take the best of the precautions that I need to do today to prevent myself from getting COVID. That never went well with me. I said this, I had COVID twice. But maybe I could have had COVID more than twice. But those 2 times are the ones I felt I was really challenged for that I couldn't walk out of my house. I had headache, I had fever, I had muscle aches, and I said, wow, this thing is on me. Now I called somebody who came and tested me in the house, because we were also had the benefit of using rapid test kits by then, because it was nearly towards the middle of the outbreak. Mid in the outbreak, we had now the antigen test kits that were used to really look at whether somebody has the virus or not. So when somebody came, I and my family, 3 members were positive and 2 members were negative. So we had to isolate ourselves in our home, and I had to stay 3 weeks without even moving, without even coming to duty. But it was well with me. Yeah, it was well with me. So personally, I also got the disease.
Okay.
And then that's the time you realize, wow, this thing is real. Many people are saying COVID is something manufactured elsewhere and it's not a real thing. So people are making whatever out of it. I don't know. But for me, I felt the brunt of the same when I suffered COVID twice. Now, COVID as a disease, what we realized as medical team or personally is that it was worse on people who had other pre-existing conditions. Things like high blood pressure, diabetes, or lowered immunity. COVID would really take them down very fast. So my luck maybe could be I never had any of those underlying conditions or that could have maybe saved me. Otherwise, it wasn't well. You could feel you really hit. If you find a man not working or leaving his home to go and fight for the family, then that was when you could realize that this thing is really a hit. It was really bad. Yeah. With some of these new viruses, we realize that you might not know when it is ending or when it has ended. They could give you a period of like 3 weeks. Rarely would you know whether you're still shedding the virus or not, because that was something that was continuous. And then the other opportunities are that you could be hearing and then you are still exposed. So you still could pick up another variant. So and another new infection starts all over again. So those were the challenges about diseases that are either contact or airborne, where you could touch things and then you have the virus with yourself. Even if you're in the process of healing, even if you are still taking medications, you still go down with the disease. So those are some of the most scenarios. Now, when COVID came, one of the biggest challenges we had was diagnostics.
Yeah.
Because we had only 2 sites that could do COVID then around Nairobi. I'm talking about Nairobi now. Yes. We had the National Public Health Laboratories, what we used to call the National Influenza Center. Yes. And then we had the Kemuri diagnostic arm that does the viruses, the viral diagnostics in Kemuri. So those are the only 2 sites we could do this. Then we never had the rapid test kits, which could tell us immediately in like 10, 15 minutes that you have COVID or not. Yeah. So those 2 scenarios were putting us in a very brunt end of this, the other very brunt end in terms of you have collected samples. There are only 2 sites where you could take them for testing. And those sites, they'll tell you, we have enough samples. We are full to capacity in terms of what we want to test for this week. Then results would delay. That to us was torture. Because imagine you had clients who you have sampled, and the clients know you. They don't know where you took the sample. So they will come to you asking for results. Yeah. At that point, I know as well, we were also testing a lot of government institutions and parastatals. Yeah. And the CEOs from those parastatals would now, they have your number. Yeah. So they keep on calling you, where are our results? Yeah. You tested us when you picked the samples on a Monday. Yeah. This is Wednesday, still no results. What are we supposed to do with our staff? Yeah. So that used to be a big challenge for us, where we took samples and they'll take like a week or 3-4 days without us getting the results back. Yeah. So that would be a big challenge. Then in terms of isolation and quarantine, we had a few areas, and I know somebody would have talked this to you, but even taking samples from those quarantine and isolation centers was a challenge for us, because we will take the samples and somebody has finished their 10 or 21 days and we're expecting a result within 3 days, meaning they have to keep in their quarantine or isolation center longer than expected, and they will be calling on you and asking you, oh, do you want me to continue paying for this stay in this hotel, whereas it's you who is holding my results? So those could be the other challenges. And then people wanted to quarantine, and they said they would quarantine into their homes, but never ended doing the same. We still could find them hovering around in town, and we had identified that they had the virus. So that was another challenge in terms of public continuity of for the dissemination of the virus. For information, that is now communication towards telling people what COVID is, how to protect yourself from COVID, hand washing. That information was with people. And we were happy about what people did. The wearing of the mask during that period was nice. The hand washing that was experienced during the 2020-2021 period was of high caliber. People really washed their hands, sanitization and all those. So people took precautions in terms of this. Yeah, people took precautions in terms of either acquiring or not acquiring COVID. People took precautions. So the information was there.
Yeah.
And now, when you look at highly infectious diseases, COVID really shook the whole world. We've never had a disease that stopped the world from operations for that long period. At this time of innovations and quite a number of things that are there in terms of health management systems. So COVID really shook the world. But we've had other diseases equivalent to this in terms of infectivity and how the virus behaved. We've had Ebola in parts of Africa, that's the DRC, in terms of some parts of Uganda, in terms of Liberia and elsewhere. So Ebola is, in terms of infectiousness, would be worse because it's what we call viral hemorrhagic fever. That is worse than COVID. But however, it has localized. It has localized in some areas where it gets the suitable environment for transmission. COVID doesn't want to have any of those suitable regions. It is everywhere. That's why it's a pandemic found all over the globe, all over the world. So COVID's lessons in terms of management were very high. So number one, you had to protect yourself from either acquiring the disease, and number two, when you had the disease, that localized isolation or quarantine was very important for us. So those were lessons learned, that when we get diseases similar to what we did, there are ways of protecting ourselves from the disease. But we have no similarities in this near future of what we got in COVID. We had others, avian flu, which is not as serious as this because there is a link between the human body and the other vectors that handle the viruses that do cause avian influenza. So the COVID one was worse in terms of where it affected and the large scale pandemic. Yes. And COVID was. So at that point, the idea is there is no plane going to India, South Africa, Germany, the US, or wherever. So if you had COVID, you die in your country, you die in your county even, you die in your home. So the idea is then we need to make up for this. And that's how they started looking for, in my county, do I have ICU beds? In my county, can I do diagnosis for COVID? In my county, how prepared am I? So it was a awakening call to the politicians that what they needed to do is to invest more in health, and they did. The investments we are having, like here in Bagadi, in Mama Lucy Hospital, was courtesy of that awakening call. People realizing that if we have COVID or any other disease that could broke and tame the whole world to people staying in their houses, then this could be serious. So in terms of health systems, yes, we realize that they are positive things. One of them is we have now increased the number of diagnostic centers across the country, not only in Nairobi. And then the increase in numbers of the diagnosis is we also brought in kits that could test for COVID instantly. What I call instant could be 20 or 30 minutes. We don't need to wait for a day or two to get results. So we had rapid test kits. That was a plus in the health system. We never had these kits initially. And then for the bigger machines that were now doing polymerase chain reaction, we took call PCR, the big analysis for COVID, we got 2 centers in Nairobi for the public for free. And that was now Bagadi Hospital and Mama Lucy Hospital. For free, we could test for people. Now, with the big machines, we could be able to talk of the variants. We could be able to talk of it's more sensitive and more specific towards the isolation, because number one, it does what's called polymerization. It increases amplification. It amplifies the number of viral copies in a sample. The rapid test might not amplify that much, but the big equipment would amplify the number of viral copies to make a good number, and then it could be able to tell whether somebody has a raw viral load of COVID than another one, and that the kids might not be able to pick that.
Okay.
Yes. Maybe the interesting part of this is that at times you go to an area and everybody wanted to be tested, and you are not carrying enough materials to test. So that for us was a plus. How people having that enthusiasm to come to stand in front of us, and we tell them, we're waiting for the more kids to come. They tell, we will wait with you. So, and when they live there with the results, because for the rapid tests, we were giving results instantly. So we already tell somebody to wait for 20 minutes and they get their results. Now, that was, for us, that was a plus. And then the knowledge of that somebody has the virus, then when we tell them how to protect them from giving the virus to others, the cough etiquette, the hand washing, the sanitization, it came very well when you identify somebody has the virus. They picked that information very well. So that for us was a plus. The people are enthusiastic in terms of wanting to know, what do I do after this now, if I am positive?
Yeah.
Before the I said was on, earlier on, we were working very well with the community. The community was perceptive. They were positive towards, I have the virus, I have to protect myself, I have to protect my people from getting this. Yeah, this profession, in terms of diagnosis, I would say it was by choice that I decided to be a medical lab technologist by profession. I had the passion. Before I joined, I only knew they used microscopes.
Yes.
Only to realize that I could work without even a microscope in a lab, and I'm still churning out or giving results. So the passion to be in this profession, one, I liked biology and chemistry and physics in school, and mathematics because it's involved a lot in this. And then that passion found me in college, where I trained as a medical lab technologist, and then came out and went out to start this work. I started working in Marsabit. I worked there, I think, for 6 years, came back to Nairobi, worked in Mathare Hospital for another 6 or 7 years. I went to work at the spinal injuries. Then I came to the province, then Nairobi, and I am still with the county now, still doing this. But currently what I'm doing is less of diagnosis now. I'm doing coordination of laboratory work, making sure that they are capacity built in terms of information that they have, making sure that they have commodities, equipment, reagents that are used for testing as a whole, having to know that they are able to test due to them having reagents and equipments that are well serviced. That for me is now the passion that climbed on top of what I wanted to do personally. But if you remember what happened in countries like Brazil, France, Italy, the Americas, generally the Americas, and partly India, people dying in droves and even having no mortuaries, and then doing mass graves, that never occurred much in Africa. Like in Kenya, we lost nearly, maybe, I don't know if the correct data, but somebody should have, nearly 5,000 to 10,000 people, only in that span. Those were COVID-related, and I think that's what that was like an hour's death in terms of in some of those countries. In an hour, you could have 10,000 people gone. So in a day, you could have quite an, and people saw these statistics they were saying if Africa gets this dose, then we'll be wiped. The whole of African continent will be wiped.
My name is Eric Inda. I work for Nairobi City County Government, and I control a program called Water Sanitation and Hygiene. As you know, when COVID started, we realized that it's more of hygiene. And if you look at water sanitation and hygiene program, mostly the component of hygiene has the domain called personal hygiene. And this is all around hand washing and provision of infrastructure that can support the behavior that we're talking about. And another thing is on environmental hygiene. And we knew that the disease was airborne, so there was need for WASH officers to see to it that our environment is sterile. So we were forced to come up with like environmental hygiene activities like disinfections and stuff like that. So that's that's when the county saw the need of like now supporting the WASH program to like come up with those intervention measures. First, we were supposed to like provide infrastructure that would support environmental hygiene activities in health facilities. That's coming up with hand washing points in health facilities. Things to do with like wearing of masks, provision of like masks to everybody working in health facilities. There was a component of wash commodities like the chlorine granules, the jik bleach and stuff like that for disinfection. There was also an aspect of waste management, because remember at that particular time any waste in the facility was hazardous and stuff like that. And at the community level, we were also supposed to set up like hand washing stations, create awareness, and provide masks where possible. And this was done at the household level and at the community level. And at the same time, at the community level, we were supposed to provide soap for hand washing and chlorine solution for disinfection, and maybe coming up with mild solutions for hand washing and stuff like that. So basically those are the things that we're doing. Then like the bigger component was now creating awareness on COVID-19 and stuff like that. Those were done both at the facility level and at the community level. Yes, what I can say is that we were at that particular time it was correct because we didn't know what we were dealing with. We didn't know the route of transmission. We didn't know how to handle situations and stuff like that. So what we knew was just to quarantine and isolate the people who have signs and symptoms. But it didn't work for long because it caused stigma, and most people went to hiding because they didn't want to be perceived as like COVID patients and stuff like that. So it worked for a while. Then later on we realized that there's a better way that we could go about it. Creating awareness, home isolations, talking to suspected cases over the phone, tagging healthcare workers to patients and stuff like that. So like we advanced, then putting on like temperature gadgets everywhere and stuff like that.
Okay.
Yes, it was a challenge because like when you look at what we now came to do later is home isolation. Home isolation was not working because like you just know how people live with the informal sector. There's not enough space for isolation at home and stuff like that. That's one. Two, there was a problem on the distance and meters that we are talking about. Keep it was something to do with 1 meter apart and stuff like that. It was not tenable in informal settlement. Then three we are talking about immunosuppressed communities in the informal settlement because one there was an aspect of nutrition that we realized later that if your immune system is compromised, then you're prone to that and stuff like that. Then another thing that came to play was the kind of housing, because informal center we have poor housing. So poor housing, lighting and ventilation is poor, and we know that COVID-19 was thriving in areas that there's no proper air circulation and stuff like that. So informal settlement, there's nothing like that. Mm-hmm. Then lastly is the quality of water. We are not sure of the quality of water in the informal settlement, and this was much due to like interferences with the supplies and stuff like that. And now this forced us to like now do a serious water quality surveillance because we depended on this water for hand hygiene issues and stuff like that. Yeah. So basically those are the challenges that we are facing in informal settlements. Then lastly, what I can talk about was management of the mask at the community level, management, use and stuff like that. Yes, it was a very, very big challenge. But we learned gradually as time went by, and we copied happenings in other countries and stuff like that. Yes, then we customized them to our context. Yes, I can remember that our meetings were ad hoc. By ad hoc, I'm talking about we were meeting when need arose, because remember that particular point, we didn't have even the commodities to support our actions.
Okay.
We didn't have enough masks. we didn't have enough gloves, and we didn't also have enough testing kits and facilities that we would say that were quarantine areas for testing and stuff like that. So we were doing a lot of resource mobilization, and we were learning a lot and putting into place what we thought would be right at that particular point. But we just know with our population is that they are always skeptical of anything that comes new. But this was now different because when COVID started, there was a narrative that this is just a story and this is just a hoax. Because they were asking themselves that have you seen somebody suffering from what the government is saying? But later on they came to now realize and learn that what the government was saying was true and stuff like that, because they were now affected directly.
Yeah.
Yes, and they were seeing people getting sick and dying and stuff like that. Yes, we were confused because like you remember the incidents that happened in I think in Sia County, whereby like we were managing a COVID case like an Ebola case. But for me, I think it's always said that you're dealing with something that you don't know. You must take measures 100%. You should not leave any loophole. Yeah, you should like fishing, whereby like you use a big net that will catch like everything that you want. And for us, in terms of disease surveillance, we were we call it standard case definition was broader, so that we can capture like all the signs and symptoms that we needed, so that we could not let any signs and symptoms outside. So that's also what was happening with burial, because we didn't know exactly how this thing can be how this disease could be transmitted. So we didn't want to like let anything go wrong.
Yeah.
Yes, but later on we learned, and we realized that these charges like compared to Ebola was not so much harmful and stuff like that. Yes, but what we used to do is that when we identified a COVID death, we were communicating with like all the coordinators in the county. So like for example, if like a body was going to for example Kisumu County for burial, we would communicate to all the border towns that the body was passing through. So if it's Kiambu, Rift Valley, yes, we were like passing the body to the next county until it was buried. Yes, that's what we used to do. At the first place, what we used to do at your border town is that we were doing disinfections. Yes, we were doing disinfections using like a week with the chlorine solution to like maybe the casket, the vehicle and stuff like that. Yes, transferring it until the point of burial. Then like at the point of burial, there were health workers waiting for the body, and like the body was supposed to be buried immediately. So we were timing the traveling time to like ensure that the body gets home at appropriate time, that it should be buried immediately. Later on we learned, and like now what we are doing is that we were giving homes hours. Then like we were ensuring that there is no eating, there was no preparation of food, and there was no gatherings around the burial sites and stuff. What I can say is that we must always be prepared for emerging and re-emerging diseases. Every country needs preparedness, and we must be aware of emerging and re-emerging diseases. And at any given time, we must have infrastructure that can support emerging and re-emerging diseases or events. I can remember when we started responding, we were not going back home, because you will never know what you're taking back to your family and stuff like that. When it started, even the healthcare workers were being like evacuated from their dwellings, like the way we used to do it, like people coming up geared, and that like brought stigma around where you stay and stuff like that. Yeah, so like this day now we came up with a formula whereby like we will call you and tell you you've turned positive, so tell us where you can go and we can get you. Yeah, so you will walk away from your house and probably go somewhere, then we pick you up. Yes. Later on I lost almost close to 6 relatives due to COVID. We have like relatives who succumbed to it. Yes.
My name is Ann Boraya. I'm a nurse working at the vaccine depot here at Kibra Sub-County, covering part of the Kibra, Nairobi County. When COVID started, we were here at Mbagathi Kibra Depot, where we were storing most of the COVID-19 vaccination. It was a shock to us because we had not known what COVID was. We saw what is this giant that has come to us. So we decided to have this depot so that we can store our vaccines and for our people to come. As we all know that COVID infection was really a danger to us because it was killing people and we were not understanding how it came about. So at Mbagathi here, we were the ones who started the vaccination. That is in March 2021, when now people had to come. We had admissions here. They were admitted at our wards, and now we needed to protect our community. So the vaccination was quite hectic because you could find many people coming. Since morning, we could open by 6. You find a very long queue waiting for the vaccine. There and then we know people were so mindful of their health and they really wanted to protect themselves. Yeah, so since then we've been giving the COVID vaccination. We started with AstraZeneca. Then after AstraZeneca vaccine, we had the Janssen's and the rest of the vaccines that came in. Up to today, we are still vaccinating, though the numbers have reduced so far. I still believe the disease is still there, though now, because we've vaccinated so many, they've gotten that herd immunity. But we still want to reach more. Like right now in Nairobi, we've reached 58.9% of our people. We are still targeting to reach 100%, so that there and then we'll be sure that our people are protected from this COVID infection, because it's still there. Yes, we still inform the communities. We still encourage them to continue with hand washing. We also encourage them to protect themselves and also get the vaccines. Thanks to the ministry, when it started the community health promoters, we have them in our community. They are our spokespeople. So they keep on preaching and also telling people to get the vaccine. So it's very, very important for them. Okay, for now we've reduced so far, but when we had now the intense time of COVID, we started the initiative. We also had people walking around with public speakers, telling people about COVID vaccines. We could go door to door to vaccinate them, because most of them were not coming to our facilities. They were thinking the health centers have people with COVID. So we were going door to door to vaccinate them in their homes, just like polio. Yeah, just like polio campaigns. Because for now, we have polio campaigns with us here in Kenya, especially in Nairobi. And we've been moving from door to door. We inform. We also look for these children by using the community health volunteers. Each of the community health promoters, they have their own households where they identify these children. Same case with COVID. So when they have their dialogues or their meetings at the community, we keep on encouraging them to talk about these infectious diseases, to talk about COVID, to talk about childhood immunizations, so that, because we all believe that prevention is better than cure. So once we prevent, we'll be able to reach many and avoid the issue of admissions in our hospitals. Yeah. So for the community health promoters, when COVID came, we had to also to take them through what COVID infection was, the importance of the vaccines, so that once they have the knowledge, they can deliver it at their communities. Most of them, they meet their households either weekly or even monthly. They have their own meetings in their households. So we keep encouraging them to encourage the community to get the vaccines, to get COVID vaccines, because once they are protected, if we reach that large number of people, we'll have what we call herd immunity. So that is what we are anticipating at. So they're the ones, they go around and they still inform people about COVID. During that time, we were so worried. So including even my family, because they knew I'm seeing these patients, I'm seeing these clients, because you could not tell who has the COVID unless they start having coughing, having shortness of breath. Once they are diagnosed is when now you realize this person has COVID. The issue of wearing masks. We were working with masks like from everywhere you go. And now my family, knowing that I am a nurse and knowing that I'm meeting the clients or our patients with COVID, At times I used to go home. I get home worried because I don't know if I have the infection with me or I do not have it. Until it reached a point I could just knock my gate using a stone for them to bring me some sandals to change so that I don't go home with what I've worn, what I used from my workstation. It was really bad. You could even get discriminated in your own house because now they know maybe you've carried the infection with you. Yeah, and then we were very worried. Yeah, and also at our workstation, you could not even trust your next colleague. It was like, maybe today he has gotten that infection. Yeah, so wearing masks, hand washing, and it was really tough. Yeah. And also meeting people here, they come, they're worried, especially when the vaccine now came. It's like everyone was rushing into getting the vaccine. Because when we had the vaccines in our country, that is in Kenya, we started with healthcare workers. Now we wanted to protect the healthcare workers and the key people in the community. So because now it was for the healthcare workers, the other people in the community, they felt like they've been left out. And all of them could rush and demand for the vaccine. Yeah, so that's why we were so overwhelmed, with the number of people who were coming. I've lost colleagues through the COVID, and during the COVID pandemic, which was really, really sad. But all through, we managed to come out well, and we are here. Yeah, every time we could look at the news, we could see at the rate of the infections. We could see the number of people who are infected. Every time, this is the number of people who have been infected, new diagnoses. In our wards, we had so many patients. But now when we started discharging people, they go home happy, they go home alive. When we had reached now, our number for immunization had reduced. The long queues had reduced, so we knew we've reached our people. Now when we had it's just 4% of the infection rate, we were feeling a sign of relief. We knew that we've reached our people. But we still emphasize to them that it can still come back if they're not vaccinated. Okay, we still have the booster shots because once someone has gotten the first dose, it's not enough because it's like the system has been triggered into building antibodies against the disease. So when they come for their second dose, now it is at standstill, and we know now there's a bit of protection. So we initiated the booster dose, and people came for the first booster. But when the second booster was being introduced, it brought a lot of challenges that we need also to go back to the community. We also educate people, but it is still a challenge on the second booster. But a few who know about it, they come for the vaccine. So we are still, we still have outreaches. We still go to their facilities, to the community, to inform them and also encourage them to come for the booster shots. So if you get the booster, we believe now you are safe from the infection, but we still encourage you, not because you've gotten the booster, we still encourage you to continue with hand washing. In case there is another infection, don't just go into the place without any protection, because you can still get the disease, but at a milder. So through health education, sensitization to our community, and the ones who know the importance, they were coming for it. So we managed to dispel all the myths and tell them the vaccine is safe for them. And also we had this challenge of why is it that COVID vaccine has taken a short time to be developed. We are also telling them this is a pandemic, the disease was really killing people. So we had to step in for now them to get protection. And we also had a myth of maybe it's a form of family planning. There's this myth that we wanted to clear all the Africans. Yeah. So all that were the myths, misconceptions. So we decided now to move fast with the community health promoters, because they're the ones who are trusted, now community stakeholders. They're really trusted in the community. So we had to empower them.
Good afternoon. My name is Judy Masharia. I head Community Health Services in Nairobi County. And let me say that during the COVID-19 vaccination, I used to do home-based and isolation care. whereby we are placing people under home-based care. At home-based care, we are placing them there for 10 days. They used to sign a consent form to say that they have agreed to be isolated at home. These people who are being isolated at home were the asymptomatic ones, the ones that they could not show any signs and symptoms, but they were positive for COVID-19. And would visit them for 10 days with my team of home-based care. So we had challenges because it was a new thing. Then you're telling someone you're isolating them in their household. And for you to isolate them, you used to check whether their household is big enough, has space to make sure that at least if they take one room, like the bedroom, they can leave the rest of the room to the other people. It was easy in the middle class, but the high class was a bit tricky. The informal settlement was not doable because in the informal settlement is where you used to have, the informal settlement, they share the latrines, they share the bathrooms, it's one roomed. So it was quite difficult, but God helped them. Actually, I can say that God saw the informal settlement people through. But we did place several people under home-based care. So we placed over 20,000 people. So the list would come, I would filter and send per sub-county so that the sub-county community health strategy coordinators would now get the list, and then they would follow them up with the community health assistants, and to some extent, did a community health assistant. They had teams in the sub-county, the disease surveillance. It was a big team. So they would divide the houses. So now what we would do, because we would not be able to follow them physically. There were so many. Every day we'd get a list of thousands, yeah? So they would call them for 10 days, and we had a form that you are filling real time. You call, you ask them how they are doing, you give them key messages. In case they have any issue, they would call back. We call for an ambulance for people who are difficult in breathing. And so many people were able to go out of home-based care when they were well. But you'd still get someone repeating. You'd get a name, they have finished home-based care 10 days, we go for testing, they are positive again, they'd go again, but and we had even discharge forms, just like they would discharge someone from the facility, would also discharge you from home-based and isolation care, because you needed to go to work, some people, and they would show I was under home-based isolation. And let me say, there was stigma also. There was a lot of stigma. COVID-19 had a lot of stigma, even for people who are isolated at home. So that's when people would say, no, my organization, we are working from home. But most of them maybe were under home-based care. Yes, we never lost anyone. That is something that I'm proud of. We never lost anyone who was under home-based care. They all survived. And then Nairobi County had the EOC number. So if someone, the emergency operation center number, if anyone had difficulty in breathing, they would call, an ambulance would come, they would pick them and take them to the hospital. I too, from where I see it, I don't think we lost so many lives like the Western people. Yeah, because we understood that this is COVID and people are scared about it and people would act. So to me, I think the healthcare workers did their best. We never took a break. We made sure that, people are free from COVID. And even today with the vaccination, which we are really insisting to people to get vaccinated. Yeah, I think we did well as a country. I think there is a lot of satisfaction with seeing the community satisfied, that they are happy with what you're doing for them. They are happy they are getting out of home-based care. They were happy that, they are good now, they are healthy. So when you see people reuniting with their families, being happy, you feel good. The Bible says that, let me quote the Bible, Colossians 3:23, that we do everything as if we are working for the Lord. So even if you are appreciated or not, that joy of seeing their faces brightening up, being happy, reuniting with their families, I think is the best appreciation ever. I'm a public health officer by profession, but I have an interest with community health. So I wear several hats. I specialized in social sciences and health management. So in Kenya, we started community health services in the year 2006. And coincidentally, I loved it. So I just jumped into it. And up to today, I mean, they were in the space of community health. They're doing a lot of specialties around community health, understanding the people. And what made me to really love community health is seeing the lives of people changing. You know, long time ago, a place like the informal settlement down here, like Kibra, people used to see flying toilets, you know. And when we started community units, all that has changed. We have now community health volunteers. Now we are calling them community health promoters who are well kitted. They can be able to look at people in the informal settlement or wherever we have the community units, even in Kenya. And, you know, seeing the health of people improving really is good. You know, people die because of some some things that you would have prevented. You didn't know that you have high blood pressure, but with a BP machine, someone taking your blood pressure, or even you yourself knowing that I can be able to take my own blood pressure, you can know now I didn't need to go to the hospital to seek health care. So yeah, I've been in this space for community health for the last, it's now how many years? 206. We are in 2023. Yeah, and I love it. Yes. Working in the community, my office here is part of the places that I go to the field, because most of the time I'm in the field, I'm in the office. I have that team of community health services coordinators at the sub-county level. We have community health assistants who supervise community health promoters. Nairobi, we are having 7,480 community health promoters, and we have community units that are 748. So they are health structures. Each has 1,000 households and 10 community health promoters. Yeah. You've seen today they are receiving some smartphones, some kits that were launched yesterday.